I'm going to be recording the rest of this session tonight for Michael and for Larissa and Bella, because they each have legitimate reasons for not being here. We're going to spend the rest of tonight talking about sterile processing. This is related to assignment number 2 this week, looking at sterile products. What is sterile? Well, anything that will either go into a patient or carry a substance that goes directly into the body of a patient by one of the parenteral routes. Remember, parenteral means anywhere but through the mouth. So all products are prepared under clean conditions. That's standard in our industry, in the pharmaceutical industry, and they're clearly regulated for that. But sterile products, anything that's going to be injected into a patient through skin or into veins or anything else, has to be sterile. Otherwise, the patient is at great risk of infection. And when you inject certain things into the body, that infection can lead rapidly to death even. So they have to be free from chemical, biological, physical contamination. That's why whenever you look at a vial or an ampule of a drug that's going to be injected, you look to see if there's any particulate stuff in the bottom. That's a physical contamination. Sometimes that happens as a result of the processing. We're especially interested in biological contaminants. And what we inject can be medications, can be electrolyte solutions, can be what we call total parenteral nutrition, which is injected through a central line catheter, which has to be sterile. That catheter, by the way, is often called, referred to by the inventor's name, and you may see this, Grosjean. People who invent medical devices like to give them their names. It immortalizes them. But the reason that we inject drugs into patients is multifold. Some drugs cannot be taken orally. The stomach will destroy them, and there isn't any way that they can be given to where they can be absorbed safely. So we have to inject them. Common drugs that get to be injected are the new protein drugs that we have that are used. Many chemotherapy drugs are injected, although we have a growing number of oral drugs. Drugs that need to be used and we want immediate action. If a person is having a heart attack, we don't want to wait 30 minutes for an oral drug to get passed through his liver and into his system. So we want an immediate response. When you give a drug by intravenous route, if you remember from your injections class, it circulates throughout the body in about 2 minutes. If you give it by either intramuscular or subcutaneous, it takes about 10 minutes to be completely circulated through the body by absorption into the bloodstream that way. So we get this rapid response, but the problem with that, of course, is that once you inject it, it's there. It's not easy to get back out. So what we can do is inject these things carefully. So we want very definitely to have these as as sterile drugs. So you remember medical asepsis, also known as clean technique, basically is a way of getting rid of the majority of microorganisms. We reduce those by cleaning a piece of equipment, which we call sanitization, or we use a prep on the skin to wipe away the majority of the surface microorganisms, and that is antisepsis. Okay, so we also will scrub things before we even put them in an autoclave. Surgical instruments are often reused. There's no reason not to in many cases, other than things like cutting instruments, like scalpels. They get dull in a hurry, so we don't repeat those. But we can, other than that, we can autoclave all that equipment and reuse it. But it takes time. So when we are dealing with the issues, what we want to do is remember that when we are involved with any sort of sterile prep, the first thing we worry about is effective hand hygiene, washing our hands. You remember that too from Med 102. So anybody remember how long your first scrub of the day should take? Pardon? The first of the day?
5 minutes.
Yeah. Yeah. Depending on the source, 3 to 5, 2 to 4. But we take time. And we use warm water, because warm water helps release oils and other things from the surface of the skin that have things in them, okay? And of course, running water and friction are our friends in that. Now, how many people in our day-to-day lives wash our hands for 3 to 4 minutes in the morning? None of us. But you need to. You do wash your hands some. Most of us will give it a, soap it up and rinse it off, and that's good enough. And for the most part, that's good. But when we're dealing with sterile processing, that's not good enough. Remember that we can clean surfaces with disinfectants, chemicals. Alcohol and bleach are the two most commonly used. They also happen to be the least toxic of these materials, even though bleach, of course, is not very nice. But the bleach that we use is what we call Dakin's solution, D-A-K-I-N. And Dakin's solution is merely a 10% bleach. Basically, you get something like Clorox, or a generic form of Clorox, and dilute it 1 part Clorox to 9 parts water. That will sterilize a lot of surfaces and, well, clean them well. And actually, they lead to very good cleaning. And we alternate with alcohol, isopropyl alcohol, 70% isopropyl alcohol, rubbing alcohol, because they both do different things. The alcohol will take oils and greases, and the bleach will kill microorganisms. Alcohol will too, but it's nowhere near as efficient as grease. Plain old soap and water is good for killing microorganisms. But when we are dealing with sterile process, we don't want to have just reduced levels. We want to have none. So we have to have equipment that we sterilize and then package. Now, you remember from your asepsis class, you actually did sterilizing. You sterilized a sample of equipment in the autoclave, and you packaged it. And you packaged it in the autoclave paper, taped up, labeled and stuff. Generally speaking, that will keep things clean enough for almost everything for about 45 days. That's our standard. And then we have to run it through again. But what we're trying to do in surgery, by definition, surgery means we're cutting open a human body and therefore creating a pathway for microorganisms or other materials to get into the body. So we want those things to be free, both our cutting tools and any of the other surgical tools we use, the retractors and the curettes and other things, to be free of microorganisms, which means sterile. Obviously, we can't sterilize people in terms of getting rid of microorganisms. So what we do is we cover the body with sterile coverings. We wear, in a sterile suite, we use actual sterile gloves, not the gloves, the nitrile gloves you pull out of the box that we have in the med lab. Sterile gloves are packaged individually, and they're packaged with ethylene oxide to keep them sterile. We open them, we use them, we throw them away. We wear sterilized clothing over our other clothing when we're working. When we're working in some environments, it's even more so. We also use special handling procedures, and we'll talk about those in a little bit. We can use chemical agents to sterilize equipment and instruments. And we can use some on the surface of the body. The problem with sterilizing chemicals is it kills living human cells as well. So we don't like to do that very much. But what we have that we use is we use sterile administration sets. We use ampules, catheters. Everything in our lab situation is sterilized. We use the laminar flow hoods. We'll talk about that. When we were doing sterile preps in a hospital, we use large volume parenterals. That phrase means the bags that you see hanging in a hospital room. Anything above 100 milliliters is considered a large volume parenteral. Parenteral means it's injected. Small volume is 100 and less, and we'll use both of them. The smaller ones are also known as piggybacks because we actually have them going into the being mixed with other things that are being pumped into the patient to dose them. We have all sorts of other equipment and supplies. We have infusion pumps, vials, we have tubing, we have syringes, we have filters, because sometimes when we're filling syringes, we need to filter the material going in and then change. I remember you. I know you were told in your asepsis class and in injections, we don't change needles, but we do when we have to. We will use a filter needle if we're using an ampule. An ampule is a sealed glass container that we actually break open to get the drug out of it. And when we break it, there's a odds-on chance that little glass particles are going to drop inside the ampule. So we use a filter needle to withdraw the drug from the ampule, and that's sterile. And then we change needles before we inject it into the patient or into the IV bag that we're preparing. We have lots of solutions that we use. Normal saline, half normal saline. D5W, remember what that is? The D stands for dextrose, a sugar. 5 means 5%, W means water. D5W is 5% dextrose and water, which means it's 50 grams of dextrose in a 1 liter bag. Okay. We also have high concentration dextrose, up to D70W, 70%. We use that for mixing total parenteral nutrition. We have many other solutions. All of those come to us sterilized from the manufacturer. There is no way a hospital can sterilize the huge number of bags of liquids that we go through in a hospital setting. So we buy them that way. We also buy lots of sterile water for injection. We call that WFI. Water for injection. And it's always sterile, okay, as well. Where do we work? Well, we work in what we call laminar airflow hoods. These are hoods that provide as sterile an atmosphere as possible circulating inside the hood to reduce, first off, to reduce either bacterial contamination of our preparation or the exposure of people to the agents being prepared, like chemotherapy agents. We use them in order to make sure that that we do not contaminate our samples. In both cases, they rely on HEPA filter, high efficiency particle filters. And if we look at the design, there are two designs. If I draw out the hood, there is the vertical design in which air flows in from the outside. Why do we do that? Because we don't want what's in there coming out. We use this especially with chemotherapy agents. We don't want what's coming in to what we're working with to get out. And it gets circulated up and then out through the HEPA filter, through a pump. So what we have is a constant flow of air into the hood from the outside. And we work, it's at the top. Okay. It is, you know, obviously if we don't want things to get out, then it's just before everything exits the hood. So we're keeping things out. Microbiological research, this is not chemotherapy, but microbiological research is often done in this kind of a hood because we don't want the bugs that are in the hood getting out. So they get caught by the filter if they actually are released in some way. And they don't come out the front because the air is always going in to prevent things coming out. Then we have the horizontal hood. Okay. In which the filtering, the air is coming through the bottom and then going through a HEPA filter at the in a couple of places. There's a filter at the beginning, and then the air circulates up through another filter and blows out. So those are the two different kinds of designs that we use. They have different advantages. Okay. When we are pushing things out that are filtered, what's going on there is if we're working with a sterile material, all the air that's being forced out has been pre-filtered, and therefore what we're doing is keeping microorganisms or other things from getting in to the hood. So it's a way to keep the sample clean. The hoods are never shut down. And the reason they're never shut down is because it's a heck of a lot easier to keep them clean than to get them clean. But we still will clean them usually a couple of times a day, usually every time there's a shift change in a lab using these things for sterile preps. Someone will go in and they'll clean the interior of the hood. There's a procedure that they use for it as well. The horizontal hoods are never used with chemotherapy agents because it's blowing the stuff out right at the tech. Okay, so we never do that, and they have to be inspected regularly, and depending on what source you believe, it's either every 6 months or every year, one of the two. Okay, so but they have to be inspected by someone who knows what they're doing, which is also very useful. What happens is when you're working in this environment, your hands, and protected hands are inside the environment of the hood. You don't scratch your nose or rub your chin or do anything else because we are, as much as possible, trying to keep from contaminating what's in there. We also work well inside the hood. By custom, it's at least 6 inches, so that we're working that, and we do this with there's a drop down glass cover that we keep as low as possible while we're working within these hoods, for the simple reason that we want to, again, reduce the potential for contamination. There are what we call glove box hoods, in which actually the front of the hood is set up with long gloves that you put your hands in and work inside the hood. They're closed up completely. And we do this with really dangerous materials. You probably won't see too many of those. When you're working in a sterile compounding facility, you are working, doing very specialized work. And that specialized work requires quite a bit of training. I was talking with Chantel, and both of us have this experience. And all the time, both of us, Chantel's been teaching here for about 14 years, and I've been teaching 8 between here and Denver. And we've had lots and lots of pharmacy students. We've had a lot of students go into the pharmacy. Each of us has had exactly one student who, within a couple of months of starting work, was doing sterile preparations. Just one in all those combined 22 years of teaching. So it's not easy. However, a person who goes through the training and does the additional certification of sterile processing will see their salary increase by at least 50% because it's such a specialized area and there's a shortage. So there are, I'm not trying to talk people into working in the pharmacy. I think it's something you have to want to do. But to me, working in a sterile environment and having to do very careful work is a lot more interesting than counting tablets and capsules. So that's my bias. And that's probably because I'm a chemist by education. So I'm used to getting my hands dirty. And I love it. But that's my bias. There's plenty of need for both. But what we want to do when we're working is understand that there are many kinds of arrangements. When we're working in a sterile environment, that environment really needs to be isolated from everything else around it because of contamination. When you walk into a lot of pharmacies, several things will happen. Usually, there's some form of barrier between rooms, often a very thick plastic set of like vertical blinds. And then as you walk in, they often will have a surface that will pick up anything that's on the bottom of your shoes. It's a sticky surface, and you'll pick up that material that way. But we do that to try and just keep, as much as possible, keep contamination. But when we're going into a sterile area, it is much, much more stringent. Most sterile areas can be looked at as divided into 3 components. And I'll just sketch out, for those of you listening to this, I'm drawing out a square with a little rectangle on each side. And this is the lab, the sterile processing lab. This is an entrance that is closed off, and this is the exit for the product. Okay. So what happens is that central area is kept, generally speaking, at a slightly higher air pressure than the 2 side areas. And they are at a slightly higher air pressure than the outside environment. Why? Because we want air going out to prevent microorganisms coming in. And what happens is you go into the entrance area and gown up. And then you close the door to the entrance area and open the door to the entrance to the lab. So you go from here, have an entrance door here, and another way here, and you go into the lab and close that up. So it's a sealed system. And here you have everything you need. You've got counter space, you've got hood space, you've got storage, you've got sinks, and you have all of the equipment that you need. So you do your preparations. And then, in order to get them back out, they have to come out the exit side. And usually, often, the exit side is just a little box, big enough to hold what you're preparing. But it is on the outside. You put your product into it, and then you seal it off, and then someone else can reach in and pick it up. And this is a schematic. Not everything's going to look exactly like this. was in a compounding pharmacy that's real close to the Denver campus of College America. I used to take my students over there to visit on a regular basis. And they had a sterile suite with the nice entrance area and the suite. Of course, we couldn't go in there. They did have, however, a glass wall that you could look through. That's as much for safety for the people on the inside as anything else. Because if there's an accident, then somebody needs to know that they need help. If someone's unconscious, they can't call for help. So if there's something going on, so there's always, you can always see in. But watching these guys work, but they used to make a lot of sterile products. It's not unusual for compounders to be asked to prepare sterile products because there are a lot of really specialized products that are picked up by doctors. This particular pharmacy used to make a really neat product. We describe it as antibiotic beads on wire. And what he did was he had stainless steel wire, sterile, and he had these little plastic beads that were sterile and that he could impregnate with antibiotics and they were strung on the wire. And what was going on was he was selling these to orthopedic surgeons in the city of Denver. And they would, when they did like knee surgery or hip surgery, they would implant this wire with these antibiotics into the surgical site. And it was a tremendous tool for reducing the likelihood of post-operative infections. It's a real plague with orthopedic surgery because around joints, you don't have real great circulation. And microorganisms will appear and grow quite a bit. And if you are trying to use a treatment protocol to get rid of them, it means very high dose, very powerful antibiotics, which are also dangerous drugs. My wife had a patient one time, who was a home health physical therapist for 40 years. She had a patient one time who had a hip replacement. Now, I don't know if any of you know anything about a hip replacement, but what they do is when they do that, what they do is they replace the ball at the top of the femur with a sterilized metal structure that will function. Usually the ball itself is either falling apart or the acetabulum, the socket it goes into, has been eroded away, so they have to restructure everything. This woman, they get her onto the operating table, and the surgeon opens her up, takes off the top of the femur, and then is informed that the prosthesis was the wrong size. And when you looked at that and said, why on God's green earth did they not tell the surgeon ahead of time? They were afraid to. And I thought, I would be more afraid of the surgeon looking at me and going, with taking a scalpel right across my throat, because then he'd be mad. Yeah, he'd be mad if he couldn't do the surgery, but that was just plain stupid. So she had to go back in for a second surgery. This one got infected. And the infection was uncontrollable. So she had to have a third surgery.
Go back to the first surgery. Did they end up putting the one that was the wrong size in?
They did, because they already destroyed the top of her femur. Yeah. No, me and my lawyer would be talking to them. To be honest, it would be lawsuit time. And no, you're not going to charge me for the next surgery.
No.
You're going to do that because that's what you should have done in the first place. But nonetheless, They did. So 3 surgeries in less than a year. And if she had had that, if they had used those antibiotic beads, they were so good that there was a good chance that that infection would not have occurred. Because what it does, it releases a really high local concentration of the antibiotic and kills all sorts of microorganisms, prevents those infections. And infections are really a plague on orthopedic surgery. We felt lucky when my mother-in-law broke her femur. Bless you.
Bless you.
That she didn't get an infection. But we felt lucky, but we also felt typical because she's a tough bird. Nothing gets her down. She had 3 feet of colon taken out, and 2 days later she went home. Tough lady. Anyway, so when we are looking at compounding a parenteral product, what we're doing is working with the physician and looking at the product yourself. A lot of these things are pretty much straightforward. Somebody says, I want the patient to get this amount of this drug by IV over this period of time. All you have to do is calculate how much drug to put into the bag, and then calculate for the nurses the rate of administration. That's just a little bit of math. But the issue is what's the purpose of using sterile products? Well, as we said before, injectable products have a much quicker onset of action. We can't, since there's no first pass. Remember what first pass is? Have you heard that expression before? It's when you take a drug orally, when it's absorbed from the stomach or from the intestine, the first place it goes is to the liver, which metabolizes anywhere from 20 to 80% of the drug and gets rid of it. So it takes about 30 minutes before you're going to get drug on board with an oral dose. Now, for the most part, especially if you're taking chronic drugs, antidepressants, or things like warfarin or whatever, you're going to build up a steady state. It won't matter. But when you are looking at really trying to treat something quickly, then you want an IV product. And also, now we have every operating room is equipped with pre-made bags of antibiotic. The joke name is surgicillin because it's used by all the surgeons. But it's various different antibiotics. And every patient who goes into surgery is put on an antibiotic drip because in comes the surgeon, in comes the surgical techs, in comes the nurses, the anesthesiologists, the other techs that are around. You got 4 or 5 people in an OR. Guess what? People are covered in microorganisms. One of the things that you'll learn in Med 104, if you haven't already heard it, is that 90% of what we see in the mirror isn't us. It's microorganisms. We got about 100 trillion cells walking around in our clothing, and 90 trillion of them are microorganisms. The other 10 trillion are what we think of as us. So they come in, they're covered. So the patient is automatically at risk, no matter what we do, because we can't completely cover and then have a capable surgical team. We can't completely cover people. So we do that. So we're preparing these all the time, but we look at sometimes drugs need to go in, also in IV, as I said, because the stomach destroys them. Protein drugs, for instance. The stomach just metabolizes the protein and uses it to, build muscle or whatever. So we have to put those in by IV. We want emergency reduction of toxically high blood pressure. We're going to put them on a nitroglycerin drip immediately. So we have to have these things all the time. But the use of these continuous infusion type drugs also depends on how the body handles the drug. Some drugs have an extremely short half-life in the body. So we have a lot of reasons for doing this. Another major issue in hospitals is, of course, infections. Hospital-acquired infections are one of the leading causes of death in this country. A number of years ago, there were at least 200,000, or at least 2 million hospital-acquired infections. And about 40,000 deaths resulted from those acquired infections. So we're constantly working with these sterile products and trying to prevent the spread of infection. Hospitals are dirty places. I don't even like to visit them sometimes because you walk in and you don't know what you're going to walk out with. And so just be really careful. But another thing that is done in the sterile lab is total parenteral nutrition, or TPN. Often patients are unable to actually eat solid food. So we have a couple of other routes that we can use. One of them is something you've probably all seen, the NG tube, nasogastric tube. So you shove a tube through the nose, down the esophagus, into the stomach, and just pump liquid food. So that's not particularly different from eating things off a plate, other than you don't have to chew it. People who can't do that, we can install through the abdomen a J tube, going it directly into the duodenum, and feed that way. Just pump stuff in. People who cannot take anything by the stomach have to be fed intravenously, parenterally. And that's usually done through a very large bore catheter that's installed in the central line. Now, some of you may have had some experience or seen someone who's had experience with the central line, but it's something that's put in surgically. It is a great wide, it's like a giant syringe. It's really wide bore because TPN is composed of, is kind of a sludgy liquid. And it's composed of a mixture of lipids and amino acids for protein and sugar, dextrose, diluted 70% dextrose. And then we add vitamins, minerals, and trace elements to try and stimulate a diet. What you get.
Why does it affect the liver?
Pardon?
Why does it affect the liver?
Well, again, it's going through the bloodstream and going into the liver. The liver is circulating, so it's going through. And it will hurt the liver.
Why? What's in it that hurts the liver?
All that lipid, for one, and all that sugar. A lot of times you'll have people on TPN and they'll have them on insulin. I don't generally have much medical care, but a number of years ago I had to have my gallbladder out. And I followed the usual Burke pattern of waiting until it was an emergency. My grandfather did it, my father did it, my dad actually spent 16 days in the hospital with his gallbladder. And I did it, so, family tradition. But I went in, and so I kind of pushy about my medical care. And so I'm there after the surgery, which was, no big deal. Laparoscopic procedure that took about an hour. But they kept me in there, and they were coming in. They gave injections, and so I always say, "What's that?" And one time this nurse came in and said, "Well, it's insulin." And I said, "I'm not diabetic." "Well, your sugars are up." I pointed up there and said, "What does that bag say?" "What do you mean?" I said, "That's dextrose. Of course my sugars are up. You're pumping them into me." So don't give me insulin. Wait, we have to get your sugar down. As soon as that bag's off, my sugar's gone. So we had a couple of arguments. And I finally said, "You will stop." Am I right? I can refuse any treatment. So they were mad at me, and I cared not.
Why didn't you want the insulin?
Pardon?
Why did you not want the insulin?
There are some studies that indicate that using insulin when it's not necessary can do damage to the pancreas.
Oh, really?
Yeah. Now, nurses were trying to tell me, well, there's no indication of that. And I'm sorry, I've seen the studies. Besides, I'm only going to be here for a few days. If my sugars are high for a few days, it is not going to hurt me. It's not going to give me diabetes. So, and I don't believe in wasting medication for nothing.
Yeah, somebody else.
That's right. We have shortages of insulin, for heaven's sake. There are people who need it. So, but that's one of the reasons right there. And everything gets processed through the liver. So they watch carefully. Usually people are not on TPN for very long. One thing, it's expensive. Another is it's difficult to compound. There is a very specific procedure you have to follow. First off, you mix in the amino acids with the dextrose and mix that thoroughly. Then you add the the vitamins and minerals, and then you add the trace elements. Remember, a trace element is something that we need in very, very small amounts, but we need them. Things like iron and iodine are trace elements. We also need trace amounts of many other elements. The body only uses about 20 different elements, and most of them are trace amounts. So, but we need them, otherwise diseases. If we don't have iodine, we have problems with our thyroid. If we don't have iron, well, that's called anemia, and that has its consequences too. So we need those. The very last thing that goes in is the lipids. And that's because lipids do not mix with water. So they have to go in and be emulsified, which means suspended. And so what you see going in from a TPN bag is this beige, sludgy mess. Yeah, yellowish beige, sludgy mess going in. But it's what they need. So we have to be very, very careful about the compounding, because if we don't do it right, the lipids will separate, because they don't want to be mixed with water. And they have to go in at the right amount. So we also, use other things. This is, again, specialized training. We have computerized equipment that does a lot of it, but we have to know how to use it and how to set it up, because every patient's TPN prescription is different. Depends on the patient, what the disease are. Because the other thing that happens is we also can mix in IV drugs. I mean, we've already got a big line in. We don't need to plug another line into the patient. So we also can put in our IV drugs into that TPN mixture. So each patient has a slightly different prescription, and it's really something that we have to work with. We have a lot of different ways of doing this. Most of the time, TPN will have about 25% sugar and around 40% of amino acids. And then most of the rest is lipids. We have automatic compounders, but they need to be watched. We also have people who still do it by hand. And the last step, the adding of the lipid, it sort of looks like you're making a milkshake because you have a blade that spins and emulsifies all that lipid. And that's the way it used to be made. The other thing we do is prepare the IV bags. We don't actually fill IV bags with the basic solution, which is either going to be normal saline or some sort of dextrose solution, usually D5W. It can be a mix. We can mix them together, but we can buy those. What we do is we mix in IV drugs in these things. And a prescription or a med order will come through that will say something like, I want this patient to get 5 milligrams per minute of some drug in 250 milliliters of normal saline or 500. And so it'll be our job to actually put that drug into the bag. We do that in the laminar flow hood with equipment such that the bag goes in and is opened in the hood. It's in a sterile container, opened in the hood, racked, and then we inject the drug in. Remember, if you've ever seen an IV bag, you see 2 nipples coming out of it. One of them has a beige septum, and the other is a white structure. The white structure is where the IV set goes into, drains out of the bag into the patient, or possibly through the pump into the patient. The other one, the beige septum nipple, is where we inject drug into the bag. So we use that, and we prepare those to order. And then they need to be used very quickly because they're sterile preps. They have a very short allowable shelf life, depending on the drug. There are what we call high risk, medium risk, and low risk drugs. High risk drugs have to be used within a very short period of time of preparation. High risk is not necessarily high risk to the patient, but a high risk of the drug deteriorating in the bag. And then medium and low, longer times. Sometimes for things that are standard to use, like the antibiotic bags for surgical treatment, we can prepare them in bulk and freeze them for up to 45 days, depending again on the antibiotic. But we can do that. But all of this stuff has to be done in a hood, and it's done carefully. Mistakes made with an IV are very, very hard to correct. If you make a mistake mixing it and you realize it, you just throw it away. Hospital loses a few bucks. But if it goes into the patient, you got a problem. So all of this has to be done very, very carefully. And what usually happens is you'll have procedures to follow. If you're preparing the antibiotics for the surgery suite, you have a very direct procedure that you follow, and you just do one after the other. For other kinds of preparations, a lot of hospitals or a lot of facilities will have procedures written out for common products that are used, including TPN. I mean, all you can, there, the specialized materials, the things that are going to vary, which are going to be the trace elements, mainly the trace elements and the vitamins and any drug that goes in. You can have a general procedure that you follow. But for many things, we have to check our procedure manual and follow it. We also keep a record of everything we do. If something goes wrong, we need to trace back to the source. A few years ago, we had a problem with heparin. Heparin is an injectable anticoagulant that's commonly used. It's cheap, it's old, we understand it real well. The problem is all of our heparin supplies come out of China, and they had a problem. What they were sending, this happened several years ago, they sent over a bunch of drugs that didn't work. So, but the hospital was preparing the syringes, filling syringes based on what they were told was in the sample. So the hospital, keeping records of everything they did, was able to trace the problem back, not to them. That's the first place that somebody's going to go. Well, the hospital screwed up. But in this case, the product was banned. And that's what it took. Patients that were not getting the anticoagulant effect and were suffering the consequences. So we keep records of everything we do. We call them compounding records or medication preparation record, depending on where you are. I prefer to use a simpler title, compounding record. We do that in order to be able to say if something goes wrong, okay, our people in the pharmacy did this, this, and this. It's in the records. It was done correctly. So let's go back now and look at the components and see if there's a problem with them. And that's that's one of the reasons we do this. Also, we need to get used to keeping records of what we do. Now, you don't need to keep a record if you're working in a community pharmacy every time you fill out a detailed record, every time you fill out a prescription of tablets or capsules. You do have a record because we keep that record so we can monitor the inventory. But the records in a sterile processing situation are much more detailed and much more carefully kept. One of the other things we do, remember I told you the small volume parenterals are called piggybacks. And that's because, and you've probably seen these too, there's a big bag, there's a little bag hanging right above it, okay? And there's a line going from the little bag into a port, a Y port, on the side of the line going into the patient. And so the piggyback is plugged into there and just drips at the same time as the drug out of the larger bag. A lot of times it will be an antibiotic or some other kind of medication going into either a line of normal saline or dextrose. So we do that and we prepare those again as needed. We don't keep supplies of these things around because they're expensive and they have a short shelf life, as I said. So we prepare these as needed. So the hospital pharmacy is busy pretty much night and day. And the bigger the hospital, the busier it is. You saw in that video the first week of the robotic stuff in the UCSF hospital. Part of that was doing IV preparation. So we're beginning to robotize that. However, still requires somebody checking to make sure that everything is working fine, that all the supplies are there. There are some things that are, and this would just work best with things that are routine, like preparing, antibiotic bags for the surgery suites. The robots work very well for that. For individual patients, they're not quite there yet for individual preparation, but they're getting there. But still, someone needs to be monitoring what's going on with that equipment. We look, when we're doing these preps, what we do is we have a bag, a solution bag, either a piggyback or a large volume parenteral, into which we're going to put the medication. The medication itself comes in a vial. Sometimes that vial is a liquid, and we simply withdraw the drug from the vial and then put it into the bag. Sometimes that drug is a powder, because the drug is not stable. Wire, as I said before, is a really nasty substance. It tears things apart. It's the most necessary and the most dangerous substance in the universe, in my opinion, because we need it, but it really does play havoc with some drugs, like penicillin or many of our other drugs that we use. So what we do is we then have to figure out how much diluent to put into that vial of powder to dissolve it. And we have to make sure it's totally dissolved, because we don't put particulates into an IV bag, because then those particulates go into the patient's venous system, and that's not good. So there are also some antibiotics that actually come attached to the IV bag. The powder, the little bottle of powder is actually integrated into the bag. And what you do is to use a mechanism to break a seal between the bag and the antibiotic bottle and let water or fluid go from the bag into the vial, dissolve the drug, and then make sure it goes back into the bag. And then you don't have to measure anything. But these are for standardized doses. And they actually can be mixed I've seen them mixed by the nurses on the wards rather than the pharmacy. One thing we want to do is remember that everything comes with an expiration date. And I kind of laugh at the expiration date on tablets. I have two favorite stories that I tell. One is vitamin C. For a long time, vitamin C was known to exist, but chemists didn't have the technology to analyze it and determine its structure. And so there was but we always thought that these things were unstable. And then a chemist, I can't remember who it was right now, but there was a chemist in either the late 19th or very early 20th century who finally figured out what vitamin C was as a chemical. And it's a chemical known as ascorbic acid. Well, he had a bottle of ascorbic acid sitting unchanged on the shelf in his lab for 30 years. And yet we put a 5-year expiration date on vitamin C tablets. Part of that is it's an FDA regulation. But understanding how the regulations are put in place was lobbied for by the pharmaceutical. Another of my favorites is aspirin. Aspirin was the first real successful pharmaceutical product. And it's still one of the largest selling products in the world today. Company I worked for, Burroughs Wellcome, made an aspirin product. They actually invented their first machine that was tablet aspirin, and they had 95% of the hospital aspirin market, tablet market in the world in the early part of the 20th century. They quickly lost that out because other people figured out how to make tablets, and aspirin became a commodity. But they sold their product, and so I worked for them. We used to just be able to go down to our storeroom and get any of the OTC products that the company made. And we had another product you're probably familiar with, Sudafed. We could get boxes of it out of our storeroom. I didn't care. So I had aspirin. I had the product Emperor is the name that we used. And a number of, when I first started teaching down in Denver in 2010, I taught this class. It was one of my first classes I taught. And I was telling my students that, we were talking about expiration dates. I was telling my students that I had a bottle of Emperor on my shelf. So you have to figure this is 2010 or 2011. The expiration date on that bottle was 1985.
Wow.
And it was perfectly fine. As a chemist, I understand it. But aspirin, if it doesn't get wet, will last forever. If it gets wet, it'll decompose and just smell strongly of vinegar. But, expiration dates are for many solid dosage forms are kind of real squishy. 5 years maximum is what the FDA says, and we have to replace it in the pharmacy. Once it gets on your shelf, that's really. But sterile products are different. Sterile products, you don't take chances with. If I have a partially decomposed aspirin tablet, it's probably not going to do me any harm to take it.
Okay.
If I have a partially decomposed vial of insulin, I don't take insulin. It's just something that came to mind. But if I have a partially decomposed vial of insulin, I can be harmed. So expiration dating works, and it's really, really critical for sterile products. Because what we're doing, as I said before, once we pull that large volume or small volume parenteral bag out of its shipping packaging, it's no longer sterile. We cannot, that clock is now ticking kind of quickly. And anytime we puncture the injection port, we have the risk of introducing microorganisms. So we clean everything repeatedly and all that when we're doing this. But we do have to look at these. And that's one place that I take expiration dates very seriously. If an IV-based solution is out of date or close to it, I wouldn't use it at all, because it carries too great a risk to the patient. So that's one thing. One of the things you do, one of the first parts of any procedure is writing down all components and all expiration dates. Because even for products that you're not injecting, the expiration date you have to put on a preparation that you make in a compounding lab that is not beyond the soonest expiration date of any component. So it doesn't matter if you've got, if you're making lip balm, what are you going to have? You're going to have petrolatum, Vaseline. You're going to have something solid like cocoa butter or semi-solid. You're going to have beeswax to give it structure. All of those things for medical use have an expiration date, and we cannot compound anything that we don't expect to be used before the soonest to expire component. And it's the same with anything else. When we're doing these preparations, when we mix something into a bag, we call that an IV admixture, meaning we're adding something to the bag for administration. So it is a product that doesn't come from a manufacturer. So we are responsible for the safety of that product unless we can show that something else wasn't. There are also standards. You probably haven't been told about the United States Pharmacopoeia, which is a standard that is used for the preparation of any pharmaceutical product. So there are instructions, and there's a whole section for the standards for compounding sterile products. I have a gift from a student many years ago. She found in Kansas a copy of a predecessor document called the United States Dispensary from 1894. It's about this thick. It's full of recipes. And I randomly opened it when she gave it to me. I started laughing because the very first preparation would get me jailed today. It was an opiate preparation back when opiates were legal. So there are instructions for everything. And one thing, if you're working with any compounding, the first thing you do is look up to see if there's a recipe in the U.S. Pharmacopoeia and follow it. Follow it. If not, you have to invent your own recipe, which means you need to think about it. There are some other products that have to be sterile. One of them is ophthalmic preparations. In other words, things that you drop into your eye. You've all seen the little eyedropper bottles. They're sterile. And in fact, the sterility testing requirements for those are much more stringent than many others, because what's going to happen? Patient's going to go out, they're going to be uncapping and capping and using this. So we have to be very careful with this. In fact, if you're formulating an ophthalmic product, you have to do a 14-day microbiology test on the batch that you're doing before you can release it. And you don't have to do that with a lot of other things. We also have irrigation solutions, and you'll see these in supply where you'll see sterile normal saline, and it'll have a screw top instead of being in a bag. That's because they irrigate surgical wounds to wash the blood out so the surgeon can see what they're doing. They have to be sterile, but they are never injected. So there's a different level there. Okay, so there's any questions? All right, so the assignment for this week is to pick a product. Let's go back and look at that right quick. Assignment 2, you're to pick a product from a list of various types of products. So pick one product of the type. Okay, so one of the choices is pre-filled syringes for a single use. Well, there's lots of different ones of those that are made. So choose one. Don't make it too hard on yourself. I want you to research how it's made, what special conditions for manufacture and storage may be required, and the consequences that could arise for not following the proper procedures. Okay, so you'll have a short Word document that you'll prepare and submit. Okay, questions? All right, well, have a good weekend, everyone, and I will see you all on Monday evening. Sure.